thank everyone for joining us today for this second part of our financial webinar series for the Delta. We're very excited again today to be working with Mr. Eric Shell of Strywater Associates as our guest speaker. My name is Nick McCray. I'm one of the consultation program specialists with the Delta program. I'm here today with my colleague, Mr. Caleb Lazinski, is one of the specialists coordinators with a Delta program as well. He'll be running our technology. He's a tech specialist for us today, so he'll be handling that and the polling and getting us squared away on all of that when we run through our presentation. With that being said, we've got our introductions in the Zoom box there. Please find that, and those of you who just joined us, feel free to add your name, title, and organization to that. We'd love to know who's able to attend with us. We do want today's presentation to be interactive and informative as it can be, so please feel free to unmute yourself if you have a question to ask, or *6 if you call in on that phone number there. Feel free to unmute yourself with *6, and if not, please feel free to use the chat box if you have any questions. But just in general housekeeping, if you'll please mute your line otherwise so we don't have feedback, that's very, very helpful for the rest of us. This session will be recorded and will be posted on the website, the center's website here in just a couple of weeks for your future reference. The purpose of the financial webinar series is to assist Delta Health Systems to gain knowledge from this series that they can ultimately aid in improving the financial position of their organization. And with that being said, none of this would be possible without the support and funding from the Federal Office of Rural Health Policy, HRSA, and the Delta Regional Authority. So we certainly have them to thank for this opportunity today. And the National Rural Health Resource Center, being the administrator of the grant, Delta grant funds, we are certainly a organization committed to diversity, equity, and inclusion, and anti-racism. For additional resources and tools and other ways that you can also instill those same principles in your organization and commitment, please check out our website for more. Today's guest speaker is Mr. Eric Shell, which could probably go without an introduction. I know you all know Eric very well. He's certainly a key influential factor in the success of Delta program. He's got over 30 years experience in healthcare financial management and consulting with focus areas including rural hospitals, rural health clinics, and improving financial operational performance and developing strategic and operational plans for those organizations. So with that being said, thank you so much for your time today, Eric, and I'll let you take it away.
Fantastic. I think Caleb's got a question he just popped up there. So
yeah, I just popped up some pre-polling questions. Feel free to answer those as you see fit, but otherwise we'll turn it over to Eric.
I'm filling out the question, and just to clear it from my screen, or I can't see my screen. Hey, good. Let's see. Morning to many of you in the Central Time Zone, and thanks for taking time out of this most often a holiday week for some. And I hope everyone had a good 4th of July and long weekend. This is an interesting presentation. This is frankly a collection of what we consider best practices for rural hospitals. For several years, as I travel around the country, I probably visited 300 rural hospitals in my 25 years of consulting. And over time, what we've done is we kind of get to feel what works, what doesn't work. And at one point, somebody asked us to pull together kind of a checklist of what you consider the top opportunities for rural hospitals. This presentation, if for those of you who were on last week, if we thought there was a lot of content last week, this presentation could be a 4-hour workshop. And so we're going to jump into it. But again, it's just a collection of best practices. I encourage you to download the slides and think about them and even review them with some of your clinical managers and your finance folks and those types of, because it is a list of what we consider best practices. As Nick just introduced, if you have any questions, fire them into the chat box, and or just unmute your line and butt right in, and either Nick will he'll monitor the chat box for me, or obviously if you just feel like voicing in, please do so. This is always a better presentation when there's dialogue between the parties. So with that, let's kick off this presentation, knowing that we've got a lot to cover. This is this is kind of the high level, kind of what are the important areas for rural hospitals to get right. And if you look through this list, you say, boy, isn't that everything that we do? And yeah, it is. And but we're going to break that down and have a checklist of some of those things that we consider kind of the more important as part of the checklist. Strategy, economic philosophy, inpatient services, all of these pieces we're going to drill into a little bit more detail. So with that, and for those of you who attended last week, we believe having a strategy, having rural hospitals kind of recognize that the payment system is evolving over time, and the functional imperatives to be successful in a fee-for-service payment system are going to change as we move to a new payment system. And so one of the keys to strategy right now within rural hospitals is to maximize the world that we're in. We're in this world of a payment system that's kind of heavy fee for service, but with some payments around quality and utilization control. The payment system is going to evolve to a payment system where we're looking at alternative payment models built on fee for service infrastructure. And then finally, alternative payment models, population health type payment models and systems. And again, kind of we live in this, I'm going to see if you guys can see my pointer. We live in this world right here where we have to think about transforming our sick care system, the delivery system that predominates our healthcare world today is to caring for sick people. We have to transform that. We have to create a healthcare system, and all in this phase one of payment, this fee for service with quality and utilization, and then we have to pick up and move payment. We've identified these initiatives that we have to think about, improving quality and efficiency right here. We've got to do this today. We've got to implement this initiative because the payment system is mandating it. We have to align with primary care as the revenue centers of a population-based payment system. That's not necessarily to do today, but we plan for that today to implement in the near term. And then around rationalizing service areas, be prepared to link into other systems to take out big chunks of fixed costs. Most are not in rural. And we don't really have to implement that for several years, 10 years maybe, but strategy, plan, and then implement. So that's how we're going to transform our sick care model around creating healthcare. Think about it as crawl before we walk, before we run, before we sprint. And some of the things that we can be doing now is data analytics, patient-centered medical homes, care management, evidence-based protocols, all things that we can think about today that don't hurt our fee-for-service world. Actually, they help our fee-for-service, but position us for the future. And then start thinking about proactively picking up and move payment, because if we create a healthcare system, we get everybody healthy in our communities, and we stay in fee-for-service, we're in trouble. And so down here is maximize our own employee workforce through our own health plan. Get paid for any type of quality initiatives that are going on. We can be doing this today. We can start thinking about shared savings and ACOs. We can plan for that to implement in the future. And then finally, the full risk plans. This is going to be linked to the third one row down. But ultimately, when we bring together sick care delivery, healthcare, true population healthcare, and payment under one umbrella, we're going to have these large health systems of the future that are going to be increasingly taking on that insurance risk. Because of this, the strategies for rural hospitals have to start building in the fact of a transitioning payment system. And so, most strategic plans that I've seen in rural hospitals really just focus right here, improve quality and efficiency, and then often kind of, kind of medical staff planning, these types of things. They don't really touch on all of these because they don't, as a foundational basis, assume a payment system that's transitioning. They assume a static payment world. And my high recommendation is to start thinking about how we, what changes with a changing payment and how do we start building that into organizational strategy. So number one, there you go. The second, and this is one, I've been giving a presentation, I'm actually giving it at the Mid-South around kind of the key 3 success factors of rural hospitals. And actually within this, this economic philosophy is understanding that actually it's funny, there's 2 of the key keys to success for rural hospitals in this slide. The first, and I'll circle the word right here, is an abundance mindset. And for those of you who've heard me speak in the past, I speak passionately about abundance mindset, where Stephen Covey defined this back in the highly effective habits of, what is it? Geez, effective habits of highly successful people back 40 years ago. And he talked about the abundance mindset is where there's a pie of success in the world. And if you're successful, the pie grew for everybody. And he compared and contrasted that to a scarcity mindset in which if you're successful, you've taken from my pie. And what I've found is this abundance mindset and growth mentality, while not an immediate return. I mean, when we cut an FTE, we see immediate return and long-term negative ramifications. Abundance is a growth mindset in which we see growth over time. So that's right here. The next is this idea, this economic philosophy, so abundance mindset and understanding fundamental economics. And where I want to go here is to say that in most cases, the variable cost, true variable cost is defined as a cost that changes with specific changes in volume. One more lab test, the variable cost is the reagent. One more admitting a patient overnight tonight. The variable cost is, food if the patient is eating, pharmaceuticals, very low relative to total costs. And as we think about that volume, incremental volume, when 80 to 85% of our costs are fixed or step fixed, drops 80 to 85% contribution margin to the bottom line. Having a fundamental understanding of that, along with this idea of growth and abundance, leads one right to the key conclusion. And it's the way I approach every single rural hospital that we work with. And it's the reason why most are successful coming out of any projects, is this mindset focuses on how do we grow services, or how do we capture market share that's going out of town. And so this economic philosophy combined with an abundance mindset, to me, are the 2 of the 3 keys to the kingdom to successfully running a rural hospital. Anyone have any thoughts on that? I just want to touch base on it because I think this one slide says so much. Yeah, Nick, we put them to sleep already. Okay, all right. So star that slide. It's a big one. Next, we're just going to go through some different kind of clinical services, and obviously having as much of a robust inpatient presence as possible also is successful for the acute care hospitals like Blake, Franklin. That's not a critical access hospital. The contribution margin from incremental inpatient care drives the success of your organization. In a critical access hospital, the inpatient unit is so critical because it pulls a lot of overhead out of the outpatient side of the hospital into the inpatient, where your cost-based payer mix is often 85%. So it's pulling overhead out of the critical access hospitals, outpatient services, and puts them into where they're reimbursed. So having inpatient services is critical. One of the things that we like to say is that having an inpatient, kind of an emergency room admission rate of between 10 and 12%, meaning that between 10 and 12% of patients that present in your emergency room either end up in an acute or an observation admission. That's kind of a benchmark that we use. And if you haven't heard us talk about that, that's a number that we always look to. And it's a manageable number. I've seen hospitals that go from 4 or 5% up closer to the 10%, just becoming more focused on what the numbers should be. Making sure if patients are transferred to other hospitals, how do that we get them back, especially for their rehab, their inpatient rehab. One of the things that we really become known to see the value of is the defining the care spectrum, and sitting down with your emergency room physicians, your hospitalists, your nursing staff, and proactively define the services that we can be providing in an inpatient setting. I know one of our consultants, many of you know Carla, and Carla worked with several of the critical access hospitals in New York State. And the bump they got in inpatient volume, once they agreed on a proactive basis, what was appropriate for their hospital was worth hundreds of thousands of dollars. Are there opportunities around teleintensivists or e-hospitalist programs, to support nurse practitioners as hospitalists? One of the things that we like to see is, especially for the critical access hospitals, is consolidating your ICU, if you have an ICU, into the med-surg unit and calling those beds high observation immediately adjacent to the nurse's station. Great opportunity. There's often a cost-based reimbursement impact for the critical access hospitals, and also an efficiencies of more of a staffing efficient model when we can do that type of thing. Use interqual criteria and educate. I was at a hospital just recently where the default from the emergency room was admit to observation. I mean, their observation admissions were twice what their acute care admissions were. And it should be the exact opposite. Generally, when we want to, so anyway, the, how do we use the interqual criteria or interqual-like criteria to define, kind of what is it? Just an emergency room default admit to observation is, one, it's going to hurt the patient, especially in the critical access hospitals that are responsible for the 20% outpatient co-insurance. But it's just not appropriate standards of care if it should be an acute admission. There's just so much here. You could almost check the box on so much of this. Track and monitor nurse patient ratios. Generally, if you're benchmarking, and there's another slide on this, the nurse ratios, we'd like to see somewhere around 12 paid hours of nursing per inpatient day being acute, swing bed, and observation. And then this metric right here, that generally you'd want to see your observation. I've gone to 30% now. We have 20 to 25% so in other words, what this is saying is target observation at between 20 to 25. And again, I'll go 30 day observation days relative to acute days, and make sure that we've got that right. Anybody have any questions on any of this inpatient? Well, actually there's another slide on inpatient, and then I'll ask the question. Swing bed is just such an important opportunity. Let me just say, to the Blakes of the world that are operating out of acute care hospitals, PPS hospitals, the contribution margin, if you can generate $450 of revenue on a swing bed day, and the variable costs are in the $100 or $150, there's a contribution margin associated with that incremental swing bed volume. For critical access hospitals, it's a form of creating staffing efficiency. It's a form of increasing the cost-based payer mix, which then pulls more overhead into it, and often leads, there's often a direct bottom line improvement by growing swing bed services. Generally, we like to target 4 patients per 10,000 population as a benchmark. That may be high in some areas, especially with your Medicare Advantage plans being very aggressive there. But still, I mean, think about that as a potential benchmark. Have an active solicitation program. In other words, be much more proactive with the tertiary hospitals in your region. I had a hospital, actually my former colleague Jonathan Pattenberg was in the North Shore of Oahu and a critical access hospital. And they had agreements with the big systems in Honolulu where they could go online every morning, review kind of discharge, patients to be discharged that day. And within an hour, by 8 a.m. each morning, they would send a list of the patients that they'd want to care for at the critical access hospital in swing beds. Very proactive approach. And they would work with the physical therapist, the pharmacist, the hospitalist, who else? Pharmacist, and decide what patients would be appropriate and then put out that request. So good stuff there. Yeah, one of the other opportunities, and I just had this conversation yesterday with somebody, well, I don't even remember what state, sorry. And it was the non-cost, so it's the say commercial or Medicaid inpatient skilled care, where if you have a contract with Blue Cross to provide, say, a inpatient skilled care in your swing beds for $500 or $600, you can actually make money on those days. I hate to keep using the word money, but hey, I'm a CPA MBA, so that's where it falls. The reason is because the cost report imputes the cost of those services as the nursing home, the statewide nursing home rate in your state. The example we just looked at yesterday, it was around $200 was the imputed cost of these days. So if this critical access hospital could get a $450 or $500 or $550 rate for Blue Cross patients needing inpatient skilled or Medicaid, there was a bottom line impact of anywhere, $300-400 per day. And that's pure profit. And so just because they're non-Medicare or Medicare Advantage doesn't mean we shouldn't be thinking about them because of the cost report treatment. If anybody doesn't understand that, reach out to me, send me an email, and I'll explain. I'll show you in the cost report the mechanics of that. This is just showing the calculation of swing bed or growth in acute care. And it's complicated for critical access hospitals. Now, for the PPS rural hospitals, it's a much more straightforward calculation. Essentially, contribution margin is the incremental volume times the rate for that incremental day, less the variable cost for those same days. For critical access hospitals, because generally the more volume that you do, your Medicare rate goes down. Right? Because as you become more efficient, you dilute your fixed costs over more and more units of service, your Medicare rate, in this example, the Medicare rate drops from, in this case, let's see, it's the net effect of these. So it's in the 1900 down to 1700. So more days increasing, and this is a swing bed example, increasing the days reduces the overall rate because you're diluting your fixed costs. But your bottom line goes up. And the main reason your bottom line goes up is because there's in this case, adding, by doing this, what happens is you dilute your costs so that you can make money in your non-cost-based business. And therein lies, and so the bottom line opportunity here for this critical access hospital was about $300,000 by growing swing bed from 1.8 to 4.0. Any thoughts, comments, and questions around inpatient services? Please jump in. Anything in the chat? You guys are quiet. We put you to sleep. It's pre-lunch siesta.
Everybody's asking for your slides, Eric. They're anxious to reference all this golden nuggets you're sharing with us.
Yeah.
And I did pop a PDF version of the slides into the chat. Hopefully everyone can see that. If not, it will also be posted to our website in the following couple of weeks.
Thank you, Caleb.
Thank you. The next area, a very important area, is emergency room services. And we talked a little about the emergency room admission rate, between 10 and 12% is something that we should be looking at and targeting. Make sure that we have options that are not in the emergency department for non-emergent patients that present. In other words, how do we have more access in our primary care, offering walk-in clinics, extended hours, these types of things, so that we can offer a service and compete with some of the technology-based companies and the insurance companies that are offering technology-based interactions with patients. Make sure that so that's kind of what this is looking at right there. Is there an ED hospitalist coverage model that's available? I know some in rural America offer a combined, if not full-time, at least possibly on weekends or evenings, where the emergency department physician also duals as the hospitalist. You have to have the right physician, though. Sometimes it's tough to find that right person. Review the transfers. Making sure that we're not transferring too much. Generally, we like to target transfers from the emergency room between 4 and 6%. So admissions, acute observation combined between 10 and 12%, transfers between 4 and 6%. Those are the numbers that we most commonly see in those ranges. And work with your medical staff and system partner to review appropriateness of transfers and leverage development of ED hospitalist model when possible. Track, for the cost report, as the cost of the emergency room physician or provider has gone up and up and up and up, and we're seeing critical access hospitals now paying over $2 million for emergency room physician coverage. It is so important that we do detailed time tracking to make sure for the critical access hospitals that we capture those costs on the cost report. The cost of the time when the patient is not, when the physician is not in some type of medical capacity caring for patients. And so that is just so critical to get that right, because the dollars at stake are significant now. Consider lean processes to reduce throughput time in the emergency department. My favorite story here is the most efficient from a staffing perspective critical access hospital I've seen what are they? They run in, we usually target about 2.75 FTEs per emergency room visit, and they're in the 1.7, 1.8. And they actually, their CEO, it was a former IBM Lean Six Sigma guy, and they went in and evaluated their whole emergency room throughput process. And they found they actually cut their throughput time in half. And when they went in and started trying to identify waste, one of the big opportunity was the lab was waiting to batch lab tests, so that there was a delay, an extraordinary amount of delay, just because of the lab not kind of processing any lab tests that came out of the emergency room. And once they eliminated that waste, they were able to save significantly on the throughput time for these emergency room patients. So lean is a great opportunity in the emergency department. ED caps, let's make sure we're tracking performance. Often the emergency room is the front door in to many of our hospitals. It's the clinics and it's our rural health clinics or provider-based entity clinics and the emergency room. And let's make sure that we understand what our quality scores are and how our patients are perceiving us in the emergency room. And then KPIs. I have to tell you, my third key to the kingdom here in terms of rural performance. So it's the abundance mindset, it's understanding fundamental economics, and then it's a measurement mindset, a measurement, a kind of a measurement culture. And within the emergency room, let's start tracking. Let's start tracking and understanding, different metrics and comparing them to what we consider standards. So door to dock time, door to discharge, door to admit, left without being seen, against medical advice, et cetera. All of these are metrics that we should be tracking and driving to improve the performance of our emergency department. Around clinical departments, I always like to start with the idea, and so many people, I've talked about this before in presentations. Department managers, there's two types of department managers. There's the department managers that they're the catchers. They sit behind their office, and if they don't have, if their volume's down or off for the week or month, They point at the doctors and say they didn't refer to us. And those are, I consider them catchers, using a baseball, kind of a baseball analogy. And then there are the pitchers out there, and the pitchers are the ones, the physical therapists that's at the high school football game, high school football games on Friday night. It's the imaging director that's posting, their time, on Facebook, their times available and the services they provide. They're out meeting with the physicians. They're presenting the physicians the new types of services that we can have. And those managers, generally, we're seeing this volume increase. And so, one of the things is making sure that we track referrals by each of the ancillary departments, by provider, to look at trends, who's referring more, who's referring less, and to better understand who are your customers. Promote services. Let's make sure the community knows that we offer, so many of us have, kind of new and improved technology that the community hasn't seen in 10 years. They only go to the hospital once every so often. And many of us have updated technology since, and nobody knows about it. We try to keep that as a secret. Maintain reasonably updated equipment, right? I mean, when I go into a hospital and the imaging equipment is 30 years old, I literally would be thinking, if I was a medical staff, if I was a doctor in this community, and my reputation is tied to where I refer patients, and I'm referring a patient to, kind of image for an imaging service, and the technology looks like it came out of Fred Flintstone land, then it's just, it does not look well on me. And so we've got to make sure that we don't have that as an excuse for our medical staff. So maintain as much as to the extent possible, current and updated technology. Track referrals, we talked about that. Conduct return on investment analysis to determine feasibility of upgrading, replacing diagnostic equipment. And conduct pricing reviews. Often in lab, what we find is that many of our local doctors won't use our lab services. They'll refer to one of the commercial lab services because they have a more competitive fee schedule. Several hospitals I'm aware of, they've set up a separate reference lab fee schedule for their lab wholesalers. And is that an opportunity for you to attract the doctors? The other thing around lab is often the physicians will say, hey, we're using this commercial lab because they interface directly with our electronic health record in our clinic. And think about it this: if a commercial lab business who's operating 300 miles away interfaces with a doctor's office, there's contribution margin associated with those incremental referrals that we have to think about, as that we can do that too. And we can do the analysis to say, an incremental 1,000 tests, what's it worth for us to create an interface between our electronic health record and our lab system and that physician practice. The commercial labs have figured it out, and they know there's money to be made there. And I think we just have to take the same mindset. Let's see, pharmacy, the 340B, for those, probably nearly everyone on the call here, the critical access hospitals, and then even the rural hospitals that have a decent DSH percentage. 340B has just been a fantastic program. We usually like to say that we, for every 10,000 provider-based entity or clinic visits, we'd like to see between $350,000 and $450,000 of net bottom line from the contracted retail pharmacy. And if we don't see those numbers, why not? One of the pieces that increasingly is being known in the 340 business is that if a patient, and you have to check the details on this, but if a patient is referred from our primary care physicians to a specialist, and that specialist then orders a prescription, that we can tie in through our 340B program to that specialist, even though that specialist is not employed by us, as long as the patient was referred by our primary care physician. Did you catch all that? Opportunity. Nick's like shaking his head. What are you talking about? And obviously develop strategies to maximize 340B. I always, if we're not at that 400,000 roundabout amount for 10,000 340B benefit for 10,000 clinic visits, one thing I like to do is use our electronic health record, figure out where all our prescriptions are being sent. And when I say it's our primary care base, and make sure we have all top 5 of those labs participating to the extent we can. Establish relationships with retail pharmacies, and make sure that we have reasonable staffing. So again, the mindset here is around growth, incremental revenue, incremental bottom line. All of these things are kind of fit that abundance mindset. Department profitability, understand the true contribution margin of your non kind of hospital-based clinical businesses. Here's an example of a home health profitability analysis. And I highly recommend you kind of do this type of an analysis for any type of ambulance or home health, your skilled nursing facility, et cetera. And you look at revenue, and then you can go right to your cost report and pull your salary expenses on your worksheet A, your other non-salary expenses from your worksheet A, and then on the worksheet B, all the overhead costs that get allocated. But if we just look at contribution margin on a fully allocated cost basis, in this case, this home health loses about 216,000. Fully allocated costs are here, revenue's 520. But what we have to think about is there's a number of overhead costs that get allocated to the home health department that would actually go away, or they wouldn't go away if home health were to go away. And so we've come up with say admin in general, for the $72,000 of admin and general costs that get allocated to the nursing or the home health, probably only 20% of them would go away. And these become variable. Employee benefits, a much higher percent, because your employee benefits costs, if the employees were to go away, then your benefits would go away. And so we use these estimates to say, okay, what's the real variable cost? If you add that to the direct cost, in this case, the home health is still losing $94,000. But for critical access hospitals, the difference between the variable allocated costs and the total are the fixed. This becomes the opportunity cost of operating one of these departments in a critical access hospital. And we've got to figure a cost associated with this. And it's the difference between those times the aggregate cost-based payer mix to come up with the loss. So in this case, if this home health department were to go away completely, the hospital would pick up $144,000 in our estimate. The key is before we decide what to do with it is, can we grow services? Again, incremental volume, fixed costs, we can reduce these losses. Or is there other alternatives in this, maybe in a community, there's 3 other home healths, they're all very competitive. In that case, we seed the business, and recognizing that by doing so, we're going to pick up nearly $150,000 to our bottom line. Any thoughts or comments or questions on kind of the non-inpatient and emergency room, the more the ancillary departments? All right, we're going to keep going then, since we only have about 40 more slides. The quality performance improvement. It's so funny that so many of our critical access hospitals have outstanding, 4-star or moving to 4-star, some are even 5-star. And often it's the best kept secret in town. And I always like to compare my hospital with everybody within 100 miles around HCAHP scores, core measure scores, and see how we stand. And if we're the best, let's let people know about that. So this whole quality improvement is a strategic priority. We have to treat it as a strategic priority. The board medical staff have to be involved in the quality improvement and performance improvement. Multidisciplinary quality committee, it meets on a monthly basis. Medical staff champions, board champions. So all really important pieces. Report report on public metrics to increase accountability and to compete regionally on quality scores, especially if you have good quality scores. I mean, if your scores aren't so good, let's post them in the organization, maybe in internal hallways and things like that, to get people, kind of to better understand where we stand relative to others and create it as a call to action. If our quality scores are great, then let the community know and let them know that we're doing great stuff here in this town. I was just at a hospital in North Carolina last week that they had top quality scores in everywhere for 100 miles, and nobody in the community knew about it. So real swing and a miss, I would say. I think we got a lot of stuff there. Information technology. This is one of these that if you read the kind of literature outside of healthcare, often IT and the director of IT reports to the CEO of an organization. And when that's the case, it's often seen as an asset to be harvested, right? When you're reporting to the CEO, IT is an asset to be harvested. So many rural hospitals, IT reports to the CFO as an expense to be managed. And you start thinking about that, you wonder why the technology, the high-tech businesses, the Apples, the Googles, the Amazons all think that there's a significant opportunity in healthcare to make a dollar. It starts just with this idea that IT is not seen in most healthcare organizations is that strategically important. With that being said, I like to see a 5-year or some type of an extended strategic plan for IT that goes beyond meaningful use. I mean, for the last 10 years, the IT strategic plan has been meaningful use. Let's not let the government dictate what our IT strategy is. Let's take that as an input, but let's recognize IT is the backbone of a clinically safe, financially successful rural hospital and use that to drive our own strategy. And so again, that's lots of words for what is said in this slide right here. Thoughts or comments on that? Oh, cost reports. As I get to travel around the country, there's almost, I think I've only been stumped maybe 2 or 3 times in all these years of doing this around finding opportunities for improvements in critical access hospitals. And Blake, you can take a nap here because it doesn't necessarily, well, it does report to you. You're in Louisiana and you get cost-based Medicaid. But there's so many opportunities within the cost report. Just, the cost report preparers, they are excellent at understanding the details of a cost report. Absolutely excellent. They understand the mechanics. They understand the boxes to put numbers in. But what they don't understand, not living in the halls of your hospital, is they don't understand the operations of a critical access hospital. And what I've found is there's the opportunity is when you understand operations and you understand the cost report to find significant opportunity. For example, med-surg, if you look at your statistics around square feet, do we have 300 square feet per med-surg or per patient bed? That's if usually if it's less than that, you start to ask questions. Have we picked up the hallway if it ends in a closed, doorway that's not a throughfare? Physician standby time, again, in the emergency room. Generally, I like to do a calculation where if you kind of look at the percentage of compensation, let's just say 50% of the compensation of an emergency room physician is in the form of professional capacity. That means 50% of the hours in a year, 8,760, are in professional capacity. If you divide that number, so 50% times the 8,760, divide it by your emergency room visits, I like to see that number less than 25 minutes per emergency room visit. Often, what we're seeing is 50, 55, 60 minutes, meaning you are overstating your professional time, understating your cost-based percent by significant dollars. And so let's just make sure that we've got that standby accurate. Many of you, we're big fans of VersaBadge. And this isn't an advertisement for them, but I know they're one of the few firms out there that are doing electronic tracking. They've helped a number of rural hospitals pick up the right time. Are we tracking Part A time for our physicians? Often what we see is if a physician's in a provider-based clinic, you just see 100% of the time go to professional, none go to Part A. And often there's physicians. I was in a hospital in Southwest Oregon 2 weeks ago, and all the clinic physicians were 100% professional when many of them had medical directorships and other types of meeting time that would actually be Part A time. Let's get that time and leave it on the cost report. Boy, there's so many things to talk about here. Nursing admin, often what we see is charge nurses are included in nursing admin, when really nursing admin should just be your CNO and CNO's assistant. Sometimes we could put some quality in there, but most of the time it's just your CNO and assistant. Boy, and another whole page. If anyone's has LDRPs, labor and delivery in your critical access hospital, often what we see is the way we're supposed to apportion the labor and the LDRPs is you take the percentage of time that the mom's in active labor, let's say it's 20% relative to the total stay, at 20% of the cost and the square footage of the LDRP is in the ancillary department, labor and delivery. The other 80% goes into your med surg, which is your highest cost-based department. Often we don't see that calculated correctly. Bad debt, often on your worksheet EB, which is your settlement page for outpatient services. I want to see between 10 and 20% of the patient responsibility, the coinsurance and deductible, as bad debt. If we don't see that, if we don't see the allowable bad debt being between 10 and 20% of that patient responsibility, I'm asking the question, how are we getting it back from collection agencies? Are we getting bad debt back at 120 days with no activity? What's our process for making sure that happens? Medical records is another one. Medical records, the default for allocating medical records costs is just gross charges. And when that happens, most of medical records costs goes to lab, imaging, and pharmacy. And not, when we're doing this, often it's 3 to 6% gets allocated to the med surg unit, which is your highest user of medical records. And so time studies for medical records are going to get you a better result. It's going to get you more dollars to your highest cost-based department. So those were some of the findings around the cost report. There's dozens of other ones, obviously. Revenue cycle. Revenue cycle is one of the big challenging spots for rural hospitals. The hospital I was at in North Carolina last week, their revenue cycle had blown up and was a disaster for 3 or 4 years. And they estimated that they wrote off between $3 and $5 million of charges just through past filing limits and all these. They recently got in a new director who is just probably the best I've ever seen in the United States. He was a former consultant for 15 years. And now the revenue cycle, this hospital is just going gangbusters now just because they cleaned it up. But I like to think that revenue cycle, the two important drivers of revenue cycle is a measurement culture, number one, and then moving the effort to the front end. HFMA has a great list of those KPIs, those key performance indicators that we should be tracking with our revenue cycle. Here's a few of them listed here. Having a revenue cycle team that meets on a weekly basis. I had a critical access hospital in Hawaii that they implemented a weekly revenue cycle team meeting, dealing with systemic issues, using the KPI dashboards to set targets. And then where we weren't achieving the targets, use the weekly revenue cycle team to deal with the systemic issues that showed up in the lack of performance relative to KPIs. And how important, kind of getting that there. We would often, the weekly meetings, they would have clinical folks invited, to the meetings in departments. For example, lab, if there was issues with lab write-offs or something, you would have the lab director come in and they would deal with these issues, but super important right there. Third-party contracts. I can't tell you the number of hospitals that I say, well, how's your third-party contracts? When's the last time they were updated? And it's a common response. Well, the CFO before the CFO before the CFO looked at them 10 years ago. We haven't really looked at them since. And especially in today, when you have physician practices, when, for example, in 2021, when your E&M codes, the evaluation and management codes, the work component of the RV, the relative value unit, was increased 30%. There was a huge bump in payment to primary care. If we don't get those negotiated into our third-party contracts, they're not getting paid. And so we've got to really start thinking about that. Front end, moving all the effort to the front end of the revenue cycle, right? So measurement culture and moving the effort to the front end. Pre-registration process, pre-registration for any scheduled service that we have. That has a conversation with the patient around patient responsibility, using that time to verify insurance, to understand the co-insurance, to discuss how the patient's going to be paying it on point of service. Absolutely important. Point of service collections, both in the clinics and the hospitals. I generally like to target 2% of net revenue being collected at point of service. And how are we doing on that one? I'm going to just keep going because we are just running out of time. Here's another area that I know you're going to say, well, Eric, you're an accountant, so you do think this is important. But I have seen firsthand several times an organization that lacked this management accounting best practice that has installed it. And the turnaround you get out of it is almost remarkable. Where we go from managers not being involved at all in the budgets, just the CFO prepares the budget, 2 weeks before the board meeting, prepares it, here's your budget, sends it to the board, it gets approved, and then it's the budget for the next year without any input from the department managers. And then the monthly follow-ups that just because you send out your financial the department's financial statements to them on a monthly basis, if you're not requiring some type of variation analysis or feedback loop, it is heads or tails likely whether the managers are even interested in and going to look at it, because they've got other things, they got other emails to clear. And so, all of this, implementing the management involved in both the revenue and expense related to their budgets, having them buy in and be accountable to it, and then monthly department to actual kind of actual to budgeted performance by department with required variance analysis for variations in excess of the predefined threshold. And then if you have time, the quarterly operational reviews, an opportunity for the CEO and CFO to educate clinical managers on their business. All of these are best practices, and I just hope that many of you have implemented some of these. Staffing, this is just how we look at rural staffing. I would like to say that it's very seldom that we come up with recommendations around cutting staff. Most of the time, if we have excess staff, there's room to grow volume without having to add staff. Just the way this thing works, I'll just show you real quick, is that here's the department, here's the volume indicator, and here are, as we look at rural relevant hourly standards, and it's paid time, not work time, it's paid. So 12 paid hours. If you multiply the 4,500 times the 12, you come up with the FTEs, the standard, and you can see where this hospital performed across all the different departments. So having understanding, but please don't use something like this, like kind of a scalpel. This is we're pitching hand grenades. We're not pitching horseshoes. I mean, just general observations that you glean out of staffing. Provider complement practice management. Boy, we can almost do a whole nother day on this. Just really understand, if we aren't in a rural health clinic, increasingly, are there opportunities as that statutory rate increase keeps going up? I think it's 113 now. It's going to go to 120 or 126 next year, and then all the way to 190 by 2028. So for new rural health clinics, there may be an opportunity as that rate keeps going up and up and up to think about that. Looking at your contracts. So often now your contracts are just solely based on production. That's fee for service world. as we start thinking about this evolving payment system, the new performance metric is going to be around population, accumulating population. So let's start building in panel size and active panel size. Let's start building in quality scores to our physician compensation as carrots, not sticks. Lots of different opportunities here. Understand, how we stand. This isn't important. This is what this slide is really saying is, in the world of population-based payment, where a busy primary care physician with 2,000 or a practice with 2,000 active panel patients, average per capita healthcare costs in the United States are $10,000. That practice is worth $20 million in a population-based payment world. Wall Street's figured it out. Wall Street's plowing dollars and through private equity into primary care physicians. We have to understand that and do whatever we can to fundamentally align with our primary care. Service area rationalization, we're going to hold off on this. Just think about all of these. Essentially, I'll just go back and say, this is what this is plotting out is all the opportunities for value creation when a critical access hospital becomes part of a larger system. From image to purchase services to service coordination to management support. And we consider that this is value curve. So low value, high value. And we consider as we push out here, capital investment, technology integration, the value really starts to rise. Most affiliations don't get by this commitment gap right here. But the other thing I will say is for every opportunity for a rural hospital to benefit, there's a mirror image opportunity for the larger system to benefit. So don't lose sight of the fact that coming together with larger systems, there's a benefit to them, there's a benefit to us, and we have to just play our cards right. Payment system transformation. Lots of words here to ultimately say, figure out how to get paid for healthcare. Annual wellness visits, chronic care management, these types of services. Create incentives within our own health plan to encourage use of our hospital by our employees and their dependents. Understand their kind of chronic use. And then population health, patient-centered medical homes, evidence-based protocols, understanding claims experience. If you are in an ACO, how can we use that claims experience to lock down out migration and get incremental volume at that 80% contribution margin to our organization, and all of these different opportunities. So, anyway, that was way too much for 55 minutes. I appreciate you guys listening in and all the questions. Nick, I'm going to turn it back over to you.
Thank you so much, Eric. That was a very informative and fast and furious presentation, and we greatly appreciate your expertise and time. My colleague Caleb here is opening up the polling. If you all please take a moment to complete that. Feel free, we've set aside just a couple minutes here at the end for any question and answer sessions that may be necessary. If anyone was had questions that I know Eric covered that pretty quickly, but if there was something you would like clarification on, please feel free to unmute and ask someone. Chances are someone else is already thinking that same thing too. So now's your chance to get clarification if you need it. A lot of great information, Eric. Thank you very much, sir.
Looks like we overwhelmed them. Too much information overload. Hey, Blake,
good.
feel better. Feel better down there in Louisiana. Sorry to hear about the positive test.
Yes, sir. That was excellent. So I have a question for you, Eric.
Sure.
First off, I really liked your abundance approach mindset, that this incremental growth is what we're and the margin that we're trying to capture over time is really a sweet spot. I really liked how you framed that. Is there, along with that kind of philosophy, what would you say are the top 3 to 5 improvement approaches that you would say right now, that of the things you presented today, that you would recommend in terms of priorities?
Ooh,
tough question, but
yeah, that's it. I look at it and say this, that on average, if we start looking at the ACO claims data, I've talked to Lynn Barr from Caravan Health about this. Generally often within rural communities, 65% of the claims dollars, the Medicare claims dollars, are going out of town. right? And so only 35 are staying within our rural communities. Our goal is to figure out a way to capture 5 percentage points more of that volume. And that's a 15% in incremental volume, dropping at 80% contribution margin. That is a tide that floats a lot of boats. And so, with that mindset and that understanding, what we have to be is we've got to encourage our managers to be entrepreneurial. We got to get out there. They can't sit behind the plate and point, identify that one clinical department manager, your physical therapist, whoever, that it is that pitcher, and use them, showcase them to the other department managers to see how we could emulate some of what they're doing to capture this incremental volume. But I do think, ultimately it's that having that abundance mindset. It's not, first thought should not be around cutting expense. We can't cut ourselves to success. So abundance mindset, capturing 5 percentage points more of that volume that's leaving our community. And then everything else trickles down out of that. And then the measurement culture, creating more measurement culture in that. And in the talk I'm going to give at the Mid-South Conference is really about some of those things and how to do those, and some case studies of organizations that have been very successful with those.
Excellent. Thank you very much for that, Eric. And I think we're okay on the chat here. And for those of you who maybe didn't see it, we will have the webinar recordings and all the slide presentations available on the center's website as well. Just give us a few weeks to complete the series here, and we'll get those posted for your future reference and resource to share with your team. So thank you all so much for being here today. Thank you, Eric, for your expertise and time with us. We look forward to our next session on qualifying rural value proposition to existing and prospective partners on the 14th. So hopefully you all can join us back for that. Feel free to contact us at the center here if you have any further questions about the presentation today, or Mr. Eric Shell, if you have any specific questions for him. Thank you all so much for your time, and we'll give you back your afternoon to enjoy the rest of your day. Thank you very much, Eric.
Thanks, everyone. Have a great day.